good? All right. You have to do your thing.
Do I do my thing first?
You have to do your thing first.
I'm going to appoint myself to the Budget and Finance Committee.
Okay. I'd like to call the Budget and Finance Committee of the Central Health Board of Managers to order. It is Wednesday, February the 20th, 2019, and it is 5:30 p.m. Tonight, we will not discuss item number 6. And so the item number 6 is discuss and take appropriate action on 1115 Medicaid Waiver, Delivery System Reform Incentive Payment Projects, the Community Care Gollaborative, including healthcare delivery arrangements and other related community partnerships. Okay, we will follow the agenda as written, with the exception of item 6 that I mentioned before. So, agenda item number 1, approve the minutes of the following meeting of the Central Health Board of Managers Budget and Finance Committee, January 23rd, 2019. Do I hear a motion?
So moved. Do I need to actually repeat the entire? I move that we adopt the minutes for the Budget and Finance Committee meeting for January the 23rd, 2019.
I have a motion by Ms. Valdez. Do I have a second?
I'll second.
I have a second by Ms. Oliver. Any discussion? All in favor?
Aye.
Aye.
Any opposed? Any abstaining? Motion carries. Okay, item number 2. Discuss and take appropriate action to authorize the execution of all documents necessary for Central Health to obtain a capital line of credit from J.P. Morgan Chase. And presenting this item will be Ms. Lisa Owens. Welcome.
Good evening. Lisa Owens, VP of Financial Operations. So we actually don't have an action for this evening. This is for informational purposes only. We're trying to get you the information, I think we say this a lot, as soon as we have it. So I want to give you what we know. There will be more coming in the future, and we will get you that as soon as we can. But I want to just walk through some details that were provided to you in a memo regarding the possibility of securing a line of credit. In the next week or two, in the near future, we may be asking for your approval to secure the line of credit and enact what we call a reimbursement resolution, which we've discussed in the past, allows us to go back and reimburse from that line of credit expenses that could be applied to that. As I said, we would share any information in advance prior to a request for action. So we are constantly evaluating our financing options for ongoing capital requirements. In addition, many times we are working on projects that have changing capital requirements, and we need flexibility to meet many of those capital needs. So it's important to have several options, including cash financing, but other multiple financing options because they will have different costs associated and different rates. In the past several years, we have many times used cash financing, and in many cases we may continue to use that practice, but the multiple options really just provide some flexibility. We do think that the access to the shorter term financing in a line of credit like this does have less costs than issuance costs of CO bonds, which we've discussed in the past. And we currently have a banking relationship with J.P. Morgan Chase, so we presented in the memo some summary of some potential terms that we could be bringing forward. We are considering this option for smaller expenditures, such as mobile clinics, modular temporary buildings, medical equipment, and furniture and equipment to outfit a medical clinic or a small modular building, as well as IT or software needs. And all of those would be in order to support the delivery of healthcare. We wouldn't use something like this for a major capital project of significant cost. That would be more of a CO, and that's another option that we would bring forward separately if there was a need for that. So with this line of credit, and based on the needs of the organization and the timing of those needs, which again, we don't necessarily know the timing of the exact projects coming together, especially with the expansion work being done in Eastern Travis County. We can draw on this line of credit in increments So on an as-needed basis, it could be in a $500,000 increment or $1 million increment. And depending on what the need is for, and the life of that asset, we could finance for 3, 5, or 7 years and have different terms for that. And that just gives more flexibility, again, to finance over the life of the particular asset being secured. So the interest rate would be based on the amount of the draw and on the assets being purchased. There wouldn't be a prepayment penalty after 12 months. And if and when draws were made on a line of credit like this, all that information would be shared with you on our monthly financial reporting. So as I said, this is just a high-level summary of some potential terms that could be coming forward, and a reimbursement resolution. And we're still in the process of exploring what those terms specifically could be with our partner, our banking partner. And we just wanted to bring this conversation forward with as much information as we had. If we asked for action, as I mentioned, we would get information out in advance in writing for you to review in advance of asking for any action. So with that, I will answer any questions if I can.
Thank you very much. I appreciate that. And I appreciate the fact that we're going to get it in writing so that we can
Yes,
review it before we get to the
absolutely.
meeting. Thank you very much for that. Ms. Valadez, you have a question?
Yes, I thank you very much for the report, hon. Okay, so this additional $10 million line of credit loan that we're gonna get, is this going to cover anything, any projects or expenses that we had previously approved in our budget for 2019? Or even 2018, and had not been expended?
Well, each time we begin to expend dollars, we would evaluate whether at that time we would want to use cash or a line of credit, or if it's a big enough expense, we would roll it into another debt financing. So this is just one option. We would not be drawing the entire $10 million at once. It would be incremental.
I think you misunderstood my question,
Okay.
or I didn't make myself clear. Would any of the possible or possibly considered expenditures, are they to cover projects that we had initially approved in either a 2018 or 2019 budget or something prior? Because if we had previously approved these things, I know we had conversations at least about expanding services to be provided to the Eastern Crescent. And I thought we had actually made a motion at one time, but I was thinking that we had previously rolled that into the budget. And so if we've previously rolled it into the budget and we hadn't necessarily expended those dollars, and here we're using that same justification for asking for a line of question, how will we know what this is really for? And if we had previously approved it and it didn't get spent on this, so we're going to apply for a line of credit, then what do we spend the money on?
So it's really an option, but we would not be expending dollars that were not either budgeted or brought to the board in advance. So we would still use our same procedures for bringing you expenditures if they're included in the budget. We would bring them based on those guidelines. If it's a new expenditure that was not approved in the budget, it would come to you for consideration. So those the budget and procurement and purchasing policies would not change. This would just be a decision as to whether we would pay cash or use a short-term financing solution.
No, I understand all of that, and I guess what I'm trying to do is back into a response, and maybe it might be better if we have a separate,
Great.
offline
I'm happy.
conversation.
That would be good.
But just so you kind of know where I'm trying to back into what we've spent, and I'm assuming this is for the purposes of CCC or Central Health. The $10 million
This would
line
be
of
for
credit.
central health expenses.
Okay, and would we be using that money for purposes under CCC, because expansion and mobile home, are we the owners of the mobile clinics then? Or we would be the owners of the modular buildings and we would be the owners of
Yes.
anything? Okay, that's the purpose for us approving that?
Yes.
Okay, thank you.
I'll schedule.
We'll follow up.
Okay, thanks.
Any other questions?
I know it may be too early in the process because we don't know terms, we don't know amounts, but is there a range of potential interest rates that they may charge? Just a range?
So we haven't gotten a final range, we just got some very preliminary, but we asked for additional information, so as soon as we get that, we'll share that.
Okay. Shannon?
So are we envisioning having these funds available for some of the initiatives we have in Eastern Preston as opposed to what we have on hand or other resources? I'm trying to find justification for why we're needing to have the 10 million out there. I understand if we have some initiatives, but are we saying basically we don't have on hand or other methods to do this other than to have this flexibility?
No, I'll go through the financial statements. It's really just an option. The cash, it's a question of cash financing or low-cost debt financing or the different financing options. And at any given time, we may evaluate what our short and long-term needs are within this fiscal year and longer term. And so it's not, many of the things that we budgeted for, we did include in the budget for cash expenditures this year. And some we included in what we call the capital budget, which is the longer term planning. So it would really just be evaluated as the need arises and the timing on that.
It gives you the flexibility.
Right.
Okay, all right, that's what I was trying to.
Okay. Any other questions? Thank you so much, Lisa. Appreciate it. Did you say something? Agenda item number 3, receive and discuss a report of the January 2019 financial statements for Community Care Gollaborative. And again, Ms. Lisa Owens.
Still here. 2 more. Okay, so I'm going to present the CCC financials through year-to-date, through January. These financials are presented year-to-date. We are caught up through January 31st. The December financials will be posted on the website, but I'm not going to walk through those and then walk through the January. Just going to go through the January year-to-date. So a few highlights just to walk through about our cash position in the CCC. It is a little bit different than last year, approximately $20 million variance, and that is due to the changes in the timing of the DSRIP program payments. And we'll talk a little bit more about that when we look at the balance sheet. Our net assets at the end of January are at $35.8 million, and this includes, in January, we completed the audit, and therefore we calculated the final net assets and a carry-forward allocation of contingency carry-forward for the CCC, and that is approximately $5.1 million. Our liabilities in January, as of January 31st, are at $25 million. And when we look into a little bit more information about the types of care, we've talked about this in previous months. The post-acute care is expected to spend approximately $2 million, which is similar to its expenditures in FY18. And this is planned to go over budget with that contingency carry forward as an available resource. So looking at the balance sheet, as I mentioned, our cash and cash equivalents is slightly less, $20 million less than last year. And we did receive the DSRIP payment in January, and that was about $24 million less than our previous January payment. There will be additional payments in that program before the end of the year. And our total assets are at $61.2 million. Our accounts payable is at $23.8 million, and as I mentioned, total liabilities at $25 million for net assets of $35.8 million. Looking at our year-to-date sources and uses, I'll focus a little bit on the sources of funds. As I mentioned, we did receive $32 million in DSRIP. The timing on that program, as you will recall, has changed. They went from a program year to a calendar year, and that was received in January. We've received member payments totaling $25 million year to date. In December, we received an additional $5 million from Seton and $10 million from Central Health for a total of $25 million. As I mentioned, we have the operations contingency carry forward at about $5.1 million that's in there after the final audited net assets. Total sources of funds year to date at $62.5 million. Our healthcare delivery expenses are just under $29 million, and we have started looking at the DSRIP program costs, the project costs. Those projects have shifted to outcomes, and outcome-based payments, but we've got some good information coming in about $3 million of project costs incurred to date. So our total uses as of January 31st at 31.6 million. Total sources over uses 30 million, just over $30 million. Looking a little bit more into the healthcare delivery programs, our primary care and specialty care, I'll go into a little bit more detail in the next slides. Specialty behavioral health is on track. We are a third of the way, or a quarter of the way through the year. I'm sorry. A third of the way through the year. So 33% of the way through the year. So we're right on track, just at about 35% in specialty behavioral health. As I mentioned in post-acute care, we're already over that budget. That was discussed, that will be, they will plan to go over budget in that space and deliver services. And again, I believe last year about $2 million of care, and we anticipate delivering a similar level of care this year. Other expenses on this line, we'll go into the healthcare delivery operations in a little more detail on the next slide. But again, our total healthcare delivery is at about 30% of our total budget. And again, 33% of the way through the year. Our primary care, we have our main primary care providers listed, and you'll see that our providers are on track at this point in the year. That care is delivered on an ongoing basis, and we work with our partners to ensure that we're on track. Year to date, we, on the volunteer healthcare clinic, that would be the, that program generally does expend all of its funds, so we will keep monitoring that, and that will be on track at the $200,000 mark, but it is at 21% year to date. But total year to date in this program, primary care in the healthcare area, is at 17 million, which is just at 33% of the expenses budgeted. And a little bit more information on specialty care. I will point out, if you look at prior year to date actual in the specialty care, which is the second row, you'll see a larger number. We have much more detailed information this year, so your year to date actual is going to actually have some of those comparatives that we carried in just one line item last year. But you will see that we have a lot more detailed specialty care breakout for you here, with the addition of pulmonology and endocrinology this year, and other areas that we did not budget specifically for last year. Overall, year to date, specialty care is at 19% of its budget, and I was going to also point out the negative expense in rheumatology. That was just an adjustment. That was a year-to-date adjustment from a prior year. So that should, that number will get adjusted over time as expenses are incurred. Our last slide goes into our operating departments. We did add a couple operating departments this year, so you won't see a year-over-year comparison necessarily, but again, we continue to be on track here at just 19% of budget, with our new department of claims payment and analysis, and a new department in strategy, community health, and population health. Those are on track as well. And with that, I'll answer any questions.
Okay, thank you very much. Ms. Valadez, did I see your?
When I speak to Lisa
You'll
about the
ask her
previous,
about
I'll ask my question.
Excellent, excellent.
Okay, thanks.
Ms. Saita?
Thank you, Lisa. Really a concern of mine as we're going in the future is once the DSRIP funds wind down, so, and giving the projects that are relying on the DSRIP funds. So are we having these discussions and how we will
Absolutely, yes.
overcome? Okay, that's just something that's always in top of mind. How can we continuing on with these programs that really resulted in great outcomes, and we just don't want them to stop.
Right, absolutely, and that's part of the ongoing planning, and a lot of those transitions to the outcomes with our partners were made this year, but that will continue to be part of the conversation as we budget for next year, and as that program, continues for a couple of years, so.
Thank you.
I'll come back to you. Manager Jones?
Yeah, just a couple of quick questions. Under the specialty care, muscular skeletal, 44%, can you sort of allude to what's going on there? Anything particularly normal, or is that?
Well, I'm not gonna say if it's normal or not. But one thing with specialty care is that it's not as consistent month over month. It's based on demand for that type of service and the timing. So we do monitor that very closely with the healthcare department at the CCC and keep track of, we are looking at the utilization regularly. But one of the issues with specialty care is that we may have utilization or need that spikes up in one month and then comes down in another month. So we are on tracking that and the contracts that support that line item, and work with our partners to make sure that if we need a contract amendment or increase to that space, that we do that.
And what's driving that also?
What's driving it? Okay.
The
Follow up on that.
second quick question is, and this is a learning curve question for me still. So this is an administrative cost for the CCC, is that right? This administration line?
This on slide 8, yes.
So these are administrators within the CCC that are funding that is coming out of central health budget.
No, this is coming out of the central health. This is the CCC budget. So the
So there's
sources and the uses here are from the CCC. So this is
so all
the
the sources are there.
administration department in the CCC.
But I'm trying to get a question, and I'll ask you offline because I think I'm trying to find out something specific about administration here as well as the other enterprise sections within
Okay.
central health. So
Okay.
I'll just ask it offline.
Okay, great.
Okay, that's it.
Thank you. Ms. Valadez?
Lisa, I just wanted to ask you a question with respect to, and thank you, Maram, for asking about the district. I've had just a question that I've had over the past few years. As we complete our DSRIP projects every year, is there a way for us to be told exactly how the results of that DSRIP project have changed the protocols or the procedures or whatever with respect to how we are conducting healthcare? And if so, is there a way for us to gauge? I think for budgetary purposes, maybe in the future, to see whether or not spending this money in this particular program per project has either positively or negatively impacted the efficiency and effectiveness of the care that's being received by our population. And I don't know, I don't know, what I'm asking for is whether or not, for purposes, when we get our reports, and we have this, again, at least with respect to the DSRIP projects, is there a way for us to be able to tell ultimately whether or not this was a good effort to continue it, or whether it was not, and we cut it off, or whether we have to change it? I'm just curious
Right.
about that.
Yes, ma'am. So, looking at the agenda item, but focusing on these budget numbers. So these budget numbers won't directly answer your question, neither will the financial reports. There is a standing agenda item that we typically have under budget and finance, as well as the board meeting, where we do talk about the 1115 waiver projects. So the short answer to your question is yes. I think to get into that today, we don't have the right staff or briefing materials here, but given that it's early because of the late start on the district project,
Right.
as those start to mature, and we have something to bring to you, not just projections, but actual results, that will certainly be part of the board's exercise.
Thank you, Mike. Did I see you? Okay, thank you, Lisa. And I guess you have one more item before maybe we might let you go. Agenda item number 4, receive and discuss a report of the January 2019 financial statements for Central Health.
Okay, so a few highlights. We did complete our audit in January, and so the audits were accepted at the January board meeting. January is generally and was again our largest tax revenue month, as taxes are due January 31st. Year to date, we've collected property tax revenue of $178 million, and we still anticipate just under $20 million in additional revenue throughout the rest of the year. We have our DSRIP year to date is at $53 million, and last year at this time it was $86 million. And again, going back to the conversation that we just had about the timing in the CCC receiving the DSRIP funds, the timing for these IGT does have an impact on that as well. And also the tax collected through January is at about 90% of the adjusted tax levy, and we will get a little bit, just in years past we've gotten 10 to 14 million in February, so we will see another pretty large tax revenue in February, but we are monitoring that, and we anticipate being on track with the tax revenue. So just looking at the balance sheet, our total current assets are at $199 million, and that's approximately additional $10 million year over year, with additional receivables. The receivables do account for intercompany receivables from our enterprise partners, and then our non-current assets consists of our restriction for capital acquisition, as well as our Sendero paid-in capital. And as I mentioned last month, we did make the $20 million transfer to Sendero in December for the budgeted risk-based capital. So non-current assets at $118 million, and then our capital assets are at $113 million, and we did not see any significant changes this month other than depreciation. So total assets at just over $431 million. We have just 25.8 current liabilities, and again, some of that consists of deferred tax revenue, which we anticipate collection. Other deferred revenue is just the timing on some rent payments. And then we have our total liabilities of $34 million, which also includes our debt service on the COs, long-term portion of the COs that we have outstanding. Total net assets are $397 million, and again, total liabilities and net assets at $431 million. So as I mentioned, property tax revenue in the month of January was just under $96 million. Our year to date is at $171 million, and that is at just about 91% of budget. Our total sources of fund, $96.9 million, and our total uses of funds, $31.5 million, and that consists of just over $30 million in healthcare delivery, which I'll go into in a little more detail next, and administrative program of just over $500,000 this month, year to date just under $2 million, and our excess sources over uses year to date at $140.3 million. I would point out that, again, similar to the CCC up at the top, year to date, when we completed the audit, we calculated the contingency reserve carry forward at $52.6 million. $41 million of that was unallocated, and $10 million of that was allocated due to IGT timing. But that is available as a source of funds going forward. Going into healthcare delivery just a little bit more, as I mentioned, the DSRIP IGT was transferred in January. There's more details on that on your slide 7, the next slide. We also had
provider costs of $117,000, total IGTs and provider costs of $28.7 million. And then looking at our healthcare delivery operating costs, I would like to just walk through the year-to-date as it compares to last year, year-to-date. There's a significant variance, and I'd like to kind of explain that for you guys. Last year at this time, we received expense reimbursement for our role as the anchor of almost $600,000, and that goes to offset expenses that may have been incurred in previous periods or that are not in that specific month. And then in addition, we are now recording our UT lease payment as an expense in this space as healthcare delivery, as well as significant operating costs for Southeast Health and Wellness Center. That was formerly a DSRIP project. It is our facility, and so there are going to be, you'll see an increase year over year in other services and purchased goods, and much of that would be security, maintenance, and utilities at Southeast Health and Wellness Center. The other costs down below where you're going to see a significant increase year over year because of the timing of when our programming started is taking over the operations of the campus. So under UMCB campus redevelopment, last year at this time we had year-to-date expenses significantly less, but we were only operating the facility for about 1 month at that time, and now we've been operating it for 4 months. And again, there are significant utilities, maintenance, security to operate those facilities, which were planned and budgeted for. So I'm happy to say we're looking good with our budget, but the year over year, I think warrants some explanation. And then also ACA enrollment and subsidy, that does include our first month of the high-risk enrollment, and so we are on track there, and those expenses are starting to be captured there, so that will be a little bit year over year increase as well to accommodate that new program. And lastly, just outlining some of the reserves and transfers as I mentioned last month. So year to date, we made our transfer to Sendero for $20 million in risk-based capital. So again, our total healthcare delivery year to date is $91.3 million. And finally, just a little outline for you on the DSRIP made in January, the CCC, UMCB, and St. David's DSRIP projects. We did make those transfers. The IGT was approximately $28.6 million. Happy to answer any questions.
Thank you very much. Appreciate it, Lisa. Ms. Oliver?
I have a question. It's more in presentation, and you do a really fabulous job of explaining things, so thank you for that. We usually go exactly where I have the questions, but on the presentation, sometimes I think it would be helpful, and maybe get the input of the other board members, to have the current month's activities compared to current month budget, year-to-date activities compared to year-to-date budget. And we don't really have that sort of snapshot because we have the fiscal year-to-date activity and the current month's activity, but there's no way to compare that to where those two periods in time are to the budget. So we've got like a fiscal year, but that's the entire year's budget, and I still like the presentation of having like how much of the budget ever used, which I think is super duper helpful. And I hate to make this so wide that, you're like looking at microscopic numbers too, but I don't know, I think that would be really helpful to have kind of month-to-date and year-to-date budget numbers, so we could see what the anomalies in a given month.
Right.
And that's really hard to track viewing it like this.
Sure.
I think when we typically have the dashboards and with the board book, but I think that dashboard actually shows your historical monthly variance based on the 3-year average. And we'll bring that back, we'll put whatever in here you need in here, but let's bring that back and take a look at it.
It's like compared to budget, not necessarily 3-year average, just budget. What did we budget and what did we spend?
Actual compared to budget,
Yeah,
I agree.
that's, I think, real typical.
That's a great ask, and it would help them.
I almost wonder if it was the ask that Richard Ewan made when he was on the board, wanting to see something like that. I guess, Jeff, do you remember that kind of? It was the same kind of comparison.
Thank you. Lisa, you'll take, okay.
We'll take a look
Okay.
and make it
readable. Thank you.
Yeah,
Sorry.
good luck. Thank you.
Madam.
Oh, thank you, Chair. Thank you, Lisa. Just, echoing what Julie's just said. So mine is actually more general to what's happening on the legislative level and how it would impact us if they will cap our property tax to the proposed 2.5. And I know it's still early, but I assume something's going to happen in that regards, and how would it definitely will impact us, and how would we recuperate those losses? And if ever. I know, poor you.
Is that a
but,
separate
well,
agenda
I don't
item?
know that, we don't have it on our agenda.
Yeah.
So I know that there's a relationship between our overall budget, which includes our tax rate, and then how much we see as assets in our financial statement. But that would probably be best taken out as a separate item related to
Yeah,
I
tax rate.
agree.
I agree.
And also, there was a memo that was sent
Yes.
with the packet that
Right.
sort of goes through that to prepare us for a discussion, and we can get it
So I
on the
hope in the
agenda.
next meeting, we'll have a
Yes.
Oh, yeah.
deeper dive.
Definitely.
Yes.
And you'll also, I think, Perla will most likely be able to tell us how the bills are doing.
Yeah.
But,
So,
yes, but it's all I would say is it's early yet,
yes,
and it's a work in progress.
yes,
And,
it's not, you're not gonna know the final ending, but
But at
You
least to
can-
prepare us.
yes.
Yes.
I would say nothing in this fiscal year, but we
Right.
will be talking about that a lot in the
The
budget.
budget.
That's right.
And when we do
Exactly,
our 5-year
right.
forecast, we'll have a lot of models
Yes.
that play out scenarios. So, but
So-
we can certainly follow up.
Thank you.
Yeah. So my guess is that you're gonna have models for that would have like, I don't know, a 4% scenario, a 5% scenario, so on and so forth. Yeah.
Okay, any other questions? Thank you very much, Lisa, and we'll let you go at this time. Agenda item number 5, discuss and take appropriate action on Central Health owned or occupied real property, including downtown campus and properties located in eastern Travis County. And Mike Giesland will give us an update on that.
Yes. Members, this is a brief informational item only, and just to let you know, because of the significance of it, both historically as well as for the Brackenridge development, we are moving forward with a demolition contract. It's with J.R. Lamont Demolition out of San Antonio, and the net cost for this would be approximately $2.6 million. But more important about this particular informational item is that, given that it is the Brackenridge property, as the demolition progresses, we'll keep you informed through the committee, as well as adjacent property owners and the public at large through the media. So we don't want anybody to be surprised when all of a sudden the building goes down. So we'll keep you informed along the way. Thank you.
Any questions, Ms. Musite?
Is it me? Oh. So going to the Brackenridge item, I know that we will start recuperating some funding for the lease by April, I believe.
That's approximate. I'm not advised on the exact month, but through the
But at least-
2033 fund.
Yes.
Yes.
So we'll
The
see
prepaying on the
some
rent. Yes.
income coming in.
Yes.
That's all.
Thank you.
Mr. Jones?
I'm just wondering, as we demolish that, are there plans to acknowledge the historic significance of that land and the hospital there? Are there plans on the way to do that, I guess is what my question is.
I know that's been, we've discussed that internally at the staff level. The ideas range from, plaques and some type of other physical attribute or improvement on the property to people being able to collect relics. Much like when they demolish a building, you'll be able to
Buy brick.
Buy brick, for example. I don't know that people want to buy a big cinder block, but nonetheless, we're trying to figure out how do we do that. I know that those have been, again, at the internal staff level, we haven't finalized anything, but we'd certainly be welcome through the committee to generate some ideas along those lines, because it is historic, and there's a lot of people that spent their entire careers there, and their kids were born there, and it means a lot to people.
But also the fact that as I've learned, it was the first public hospital in a city that a city particularly owned here.
Right.
And so I think somehow or another we need to trace its history back, and I think a plaque would be appropriate in some format, so I would encourage considering that.
Yes, sir.
I'd like to recognize Ted.
I just wanted to add that we just had a conversation about this today. So talking about a way to acknowledge and a communication cascade about this demolition, because it is more than a building. It is a piece of Austin's history. So we've talked about a lot of different possibilities, including finding people that were born there, architects who worked on the building, doing some kind of a plaque or commemoration for that location. So those conversations are happening, and we'll be reporting back to you on that soon.
Thank you, Ted. Appreciate it.
So,
Thank you.
And
Ms. Valadez,
Thank you.
and then Ms.
And I
Musayev, and then, what, do you have?
this relates just directly to what Ted said. Ted, it might be good in strategic planning when you do your update to report on that.
Great. Ms. Valadez.
And I know that when we were developing the original plans and having the community discussions, that always came up and was considered a big priority and must-do, to include the historical implications, the background, the history, and that through the master plan that we approved originally the development of, I mean, the design for, there was consideration of maybe a walking trail, talking trail, things like that, to make sure that the historical significance and the populations would be honored.
Great. I just want to emphasize that.
Yes, no, yeah.
So that's good to know. Very good, very good. Ms. Musayev?
Yes, thank you. I think when our next downtown committee meeting, we'll be discussing this more deeper on a general level. And also, when CN transferred to a new teaching hospital, they left a lot of historical paintings and so really nice items from what I've heard. They didn't take it down. So that's another thing to think about. What are we going to do with those?
Murals.
Yes, murals. So that's something that I've talked with Steve and we should, so we'll see where we'll go.
Any other comments, questions? Okay, thank you very much,
Thank you, ma'am.
members. And item number 7, discuss and take appropriate action on an update regarding Sendero Health Plans Incorporated, including the effect of federal legislative and regulatory actions. Mr. Westerkowski.
Thank you for having me. I'm happy to give you a brief update, or as brief as you want it to be, on our work and what we see for this year.
Thank you.
I can start with some general ACA information. So I can't remember if we discussed ACA enrollment. Down roughly, I think, 4% nationwide. And similarly in Texas, from what we know. We're waiting. We do expect to get Travis numbers sometime within the next few weeks, and when we get those, we'll update you on those. Likewise. It shows the importance, I guess, maybe in the resilience of ACA in face of the uncertainty and the challenges, which are ongoing. One of the other good pieces of information that came out from the Kaiser Foundation just a few days ago was how ACA significantly reduced uninsurance for minorities, anywhere from 1/4 to 1/2. It's pretty much nationwide. And if we can, of course, we'll try and find out as much as we can about local numbers. For Sendero, the quick 2018 update. We're ending the year in line with projections, and this should leave us with around 250% RBC, which is, where we want it to be and in line with prior years. Let's see, for 2019, a quick enrollment update. I think we are close to around 14,000 paid. In our projections, we're leaving it around 12,000 to leave room for some, reconciling that always goes on through our TPA. But we're happy with this enrollment. This is less than last year, but it reflects our shift to more directly support central health strategy and focus on low income and higher acuity members in our community. Based on that, we included a slide. I guess I can go to it now. So slide 3 in the deck. So this is a kind of an update of a slide that was presented originally, I think it was back in September. And this is a summary slide from, it's a little different on screen, that's fine. But this is a summary slide of the actuarial information that was used to kind of build our program and decide to move forward. And as part of that, you remember the actuaries looked at all our historical data and some of the map historical data and came up with a range of projection scenarios based upon different enrollments and different population scenarios. So this summary chart reflects 3 things. The top is the different scenarios. So there are, 9 different scenarios reflecting different populations for Sendero and different enrollments. I'm on the 3rd slide, sorry. And you see a range of membership projected from 15,000 members up to 25,000 members. MAP members, that next line refers to the number of chat members that were being sponsored. We saw ranges there from 100 up to 500. And then finally, the 3rd variable was the relative risk score for this population. And they estimated that the ranges ultimately would be from around a 15 relative score up to, 10 up to 20 for the relative scores. And for where we are today, we think we're closest to column 4. So you see we've got like all the projections laid across. The projections were in that one in the middle with the green dotted lines, projection 4, where we expected about 15,000 non-MAP regular members and 200 MAP members with an average risk score of 15. That leads us to the second, to the middle of that slide, which shows our expected capital positions. And this is in terms of RBC. So this was our regulatory risk-based capital, which is a measure, one of the key measures that TDI uses to kind of check basically the functioning, the operational, financial solvency of the plan. And you see in almost all these scenarios, we end up above 300 or 400%, which is greater, so in some sense, greater financial strength than we currently have, which is good. In scenario 4, we still expect to end this year above 400%. And then the last bottom section of the slide reflects the projected net incomes. And in this one, with a risk score of 15, the projected net income by the actuaries ended up a little bit less than $5 million. So we expect to be in that range, but however, for our projections to be conservative, we did not use 15, we used about half of that for a relative risk score of 8. So in other words, even though the actuaries would have guessed, based on enrollment that we'd come out at 15, we just said, yeah, let's be conservative and basically knock it in half. So we're using 8, and even with a risk score of 8, we still come out with break-even or better projections for 2019. So in short, we're very pleased because it lets us focus on the important thing, which is taking care of the members you gave us. So altogether, we have over 1,000 CHAP members, I think, right around, and 223 of those are directly the sickest MAP members. So with that, any questions?
Ms. Musanka?
I have a question, thank you. You just mentioned that there's 14,000 paid members, and here in current projections, you have 12,000.
So what happens in insurance is that people sign up for a year, but throughout the year, people drop off. Like, everybody can stay on till the end. So just to be conservative, we said, well, let's leave the average projection at 12,000. But it is possible that we end up higher than that.
Any other questions from the members? Hearing none. Thank you very much, Mr. Zakowski.
Just as a quick reminder on this item, the information that you heard here tonight will be used as the basis for the presentation to the County Commissioners Court next week.
Do we have a time schedule for that next week?
We have a date, but not a time yet.
Related to that question, the expectation of those board members being there, in what time frame?
We'll send something out to you. offline.
Emily sent a placeholder,
Tuesday.
Yeah, I have a placeholder, but it's all day.
and so, yeah, but
That's
she
why I
will,
asked
she
if
will
we
narrow
had
that down when they get an
So
idea.
is the expectation were to be that we've been asked?
Typically, it's if you can, and we don't know the time until at the very last minute.
Right.
It's completely optional.
Yeah.
It is
Okay,
optional.
that's
Optional,
I
and
went
we
to the
won't know
last
the
one, but-
time till the last
so I didn't
minute.
budget, okay. I have the date aside, but I have something else on that date, that's what I'm trying to work
Right.
around
All
with,
good.
so.
Right.
It's normally been in the morning or right before lunch.
Yeah, usually around a little bit before noon.
Yeah, okay.
But sometimes they don't get to us until after lunch. so.
Right. Just depends on their
I'll be on
agenda.
mTOR.
Yeah,
Thank you.
depend on their agenda, like ours.
Yep.
But I can say that we are cooking with gas tonight.
Oh, before you leave,
Okay, before you leave. Wes, Wes, Ms. Valdez
one
has
last
a
quick one,
question.
and maybe it should be directed to you, Dr. Bell or Mike. Will there be an opportunity for us to be able to have a conversation with you with respect to how this went and what we can do to tweak the process? Because I know what I've been hearing in the community with respect to how it went this year, since it was a pilot, at least from some people who were part of these.
I know that the Sendero
And some
board,
that were approached that didn't get on, and they did tell me why.
the Sendero board has been having those discussions. We definitely have on our agenda. We want to know what worked and what is the plan for going forward. If the Central Health chooses to continue to back us to go forward, we want to be ready with a plan and some ideas with regard how do we need to tweak this, or how do we need to look at maybe additional high-risk MAP patients that may need to be placed on this program.
So I guess you're almost answering my question. You did say that your Sendero board has been receiving this information or
No,
having
we
those
haven't been
discussions?
receiving,
You're
we've
going
been
to have a
discussing.
discussion.
That's right.
So at your discussion, I'm asking us if we as a board for Central Health will have an opportunity to have that discussion, because we're not on your board and I don't know if your meetings are open.
Okay.
So, Mr. Chairman, it seems to me that this is an item that falls rather like the one about the legislature and potentially lowering the cap, that it's something that we'll need to have on our agenda. As with that item, both of these items we need to have on future agendas as we go into our budget.
Definitely,
Thank you.
I agree.
Thank
And we will have that discussion.
I assume
here.
we will. Thank
Yeah.
you.
Thank you very much.
Okay, thank you very much. And
Thank y'all
Wes.
for being here.
it's not, you can keep these. It's not,
Yeah.
we didn't go into close.
Right.
I just see the red confidential letters, you know.
So, yeah, this is the first time you'll be able to keep that handout. No, not true. Thank you, Wes. Thanks,
Thank you.
Betty. I
Thank you,
appreciate
Betty.
it. Agenda item number 8, confirm the next regular committee meeting date, time, and location. The next Central Health Board of Managers Budget and Finance Committee meeting is scheduled for March 13th, 2019 at 5:30 p.m. Central Health Administrative Offices, 1111 East Cesar Chavez Street, Austin, Texas, 78702. May I have a motion for adjournment? I have a
Second.
motion by Ms. Greenberg, a second by Ms. Valadez. Any discussion? All in favor? Any discussion?
Really quick one, if possible, in the future, that we get an update on item 6, because we have not had that,
Discussion.
it's, okay, because we haven't had an update on
Okay.
item 6, that's it.
Sure.
Thank you.
All right. Any further discussion? All in favor?
Aye.
Any opposed? We are adjourned. Thank you.
Thank you.